Good afternoon, everybody. My name is Garrett Schmidt, and I'm the CEO and Managing Editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar, which is actually part 2 of a 2-part series called it's called Achieving Growth and Prosperity for Specialists Under the Risk Payment Models. Today's session is called How ACOs on the Team Can Improve Specialty Care Savings. There's a lot of material to cover, so we're going to get right to it here. A few items of note before we get started, just some housekeeping items. Today is just like always, all of our webinars is a traditional webinar format, so you don't need to worry about turning off your camera or your microphone. We can't hear you or see you, but we are going to have a time for some Q&A so that we can hear from you, and we're going to do that towards the end of the presentation. But if you have a question for either of our speakers at any point during the presentation, you can go ahead and drop that into the module there that you have, and there's a specific place for questions. We're also going to have a couple polling questions to participate in to kind of make it interactive a little bit, so keep an eye out for those. And then finally, the session today is being recorded, so when we conclude, you will receive an email about an hour or so afterwards that will have a link to today's recorded session as well as to the slides. And you're going to want to download those slides because there's going to be a lot of great material on there. So let me go ahead and at this time introduce our speakers today. With us, we have Ms. Terry Hush. She is the CEO and founder of Roji Health Intelligence, and also Mr. Dave Halpert, who is the Chief of Client Team. So I'm going to go ahead and turn it over to you guys at this time. Welcome.
Thanks, Garrett.
Thank you, Garrett. And welcome to Team Part 2, everybody. We do have a lot of material to present today. We're just going to kind of dispel the storm clouds that we have here going forward. So let's get started. Just a little infomercial to start. Why should we be talking to you about team, and why should you care about what we say? Well, we've been doing this, obviously not team, because it starts on January 1st, but we have been creating episodes of care since 2000, and we've been gathering data for 20 years now. And so we've really invested in payment models and helping clients achieve success under these kind of risk-based payment models. So stay tuned for what we have to say today. I'm going to do a little bit of a review very fast, and I'm going to focus on really high-level issues in team just to refresh the structure a bit. First of all, it's a mandatory 5-year and 2-sided risk model, meaning downside risk as well as upside risk. It's surgical episodes, and it's focused on hospitals, 743 of them for exact, in very small statistical areas throughout the country. So it's one of the biggest payment models out there. It will be probably about the same size as the ASM model that comes on next year for a couple of different conditions. The goals are quicker recovery, fewer avoidable hospital and emergency visits, shorter stays, smooth transition to primary care, and probably the big thing, lowering the cost of care. There are 5 different procedure categories. There's CABG, lower extremity joints, so hips, ankles, and knees, femur hip fracture surgical repair, major bowel, and spinal fusion. All of these are the top procedures either by volume or by cost in the Medicare program. So this is why they're under the target here. The pricing methodology starts with the trigger procedure. CMS calculates a target price, which is supposedly trended, normalized, and risk adjusted. The hospitals continue to bill fee for service, but there's a reconciliation at the end of the whole process. And once that reconciliation process occurs, there's either a payback or a bonus to be delivered. I put this in the first team webinar, and I want to go through it again because it's, oopsie. The point is, is that there is a high cost phase to all episodes, but the patient is coming in with certain risk factors already that affect that highest cost phase. So here we have a patient presenting with diabetes, is referred to a cardiologist based on symptoms, has the test, then goes to the cardiovascular surgeon who schedules surgery. At the day of surgery starts the actual episode. The surgeon, the anesthesiologist, may or may not know the real condition of that patient and all the risk factors. So that's an important thing to take away from where we are in the episode timeline, but also where you'll be in the data that you're looking at from Medicare, because it won't cover what's happening before. The patient has problems in surgery, meets the anesthesiologist the day of, surgery is performed, patient goes into AFib, which is the most common complication of CABG, ends up in the ICU, goes for a cardioversion during that process, then develops a sternal infection, so stays longer in the hospital, then finally is discharged to a rehab facility from day 12 to 20, falls, goes back into the hospital, back into rehab, and the episode ends sometime when that patient is in rehab. So you'll see that throughout this, there are various risks and costs that are emerging, and all of those need to be captured by episodes. Not all of them will be captured by the CMS episode, but the episodes that we create, for example, captures that front end process. So we know what to look for about the patient in the episode phase by identifying the risk factors ahead of time. So just to give us a heads up on where you are in the audience for your team participation, or whether you're just listening in so that you can learn about what's coming in the market, here's a polling question that we'd like to capture before we go forward, and then I can speak to some of these issues. Are you a participant in learning or participant and ready for action, meaning you feel like you've got your system built at this point, or you're not a participant and you just want to see what's happening? Garrett?
Okay, you are seeing this, or should be seeing this, on your screen. And again, the question is, what is your background with team? Are you a participant in learning? Are you a participant and ready for action like that tiger? Or are you a participant and are you not a participant and you see what's coming? And like that fox that's just waiting to see what's going on. So we are going to, what's that?
I love the look on that fox's face.
I do too. Yeah, very inquisitive, but ready for action when it makes sense. So, all right, I think most of the results have come in here. Give it another maybe 5 seconds or so. Again, what is your background with team? By the way, this is anonymous. You know, we're going to have another poll later on, and this is just for fun. So we're going to show the results here so you can see kind of where you stack among your colleagues. So, all right, I'm going to go ahead and close it down in 5, 4, 3, 2, and 1. Okay, so it's looking like we have 55% of you said you're not a participant and you're seeing what's coming. 27% are you are a participant and are still learning, and 18% of you are a participant and ready for actions. I kind of did these out of order, but it's really great for 18% of you that are ready to go.
That's great. Also, I think it's really good for the people who are not participant to be here, because we see this growing throughout the entire large volume surgical suite, if you will. Okay, and now I'm going to turn it over to Dave to talk about the ACO aspect of team.
Thanks, Terry. Yeah, I'm going to talk today about how ACOs actually play a role in team, even if they are not comprised of surgeons. So let's get started with what's at stake for ACOs. ACOs are responsible for the total cost of patient care. And so what that means is that even if you do have patients that you are not actually performing the procedure on them through your ACO, those patients are getting those procedures done. 40 to 60% or so of total cost of care comes from specialty costs. And so unless the ACO is able to drive those patients into high value specialty areas, they're going to see shared losses. Primary care alone is not enough to drive long-term shared savings. So there's value for ACOs. The value of ACO participation in team is that, first of all, ACOs may, and I say may because it does depend on the tools and analytics that they have and utilize, know what is beneath the surface for some of these patients. And when I describe what's beneath the surface, what I mean is that when we did our own internal analysis of our clients' upcoming potential with team, we found that hospital costs outpaced all others by a wide margin. It wasn't close. It wasn't skilled nursing. It was the hospital costs. And the primary variation there is complications. And so what an ACO can do is it has the potential to communicate proactively and help to mitigate some of these risks that these patients have that otherwise may have gone unknown by the hospital and the surgical team. And then post-procedurally, they can help quarterback the care management to prevent adverse downstream outcomes that some of these patients may otherwise have if they're trying to navigate this on their own. ACOs can also help hospitals achieve team. So first of all, they can help collaborate. They are no stranger to participation agreements and how the incentives work, and so they can lend an experienced hand. But most importantly, they can facilitate the data aggregation process, and that is going to be a huge benefit in team, is to understand what has happened with the patients beyond the window of claims that CMS gives. So ACOs are going to have claims data that will shed light on patients' past medical histories that the team participants would not otherwise have. Furthermore, a component of team is that there must be a discharge to primary care following these procedures, and ACOs are uniquely equipped to play a role in that, so they can be discharged into the ACO. The hospital benefits further through ACO collaborations because the ACOs can be sort of a neutral party that helps to measure some of the cost and quality associated with these procedures. And because they will have a technology platform, common analytics that help look at the outcomes for these 5 procedures in question. And if they do have the advanced data aggregation potential, they're able to use that to feed into downstream predictive AI models so that you can continually learn and get better, even if you're not at the AI level yet. It's still very illuminating to retrospectively see what has happened and why it has happened. And it improves they will improve downstream care by linking primary care payers or primary care providers, to specialists. There are also advantages for specialists. First, they are going to have the ability to get to more data than they normally would have. Many specialty practices do not have an advanced data set for being able to look at what are some of the pre-procedure drivers of cost, the post-procedure drivers of cost. They just don't have the analytics to understand that cost variation. And so if an ACO is involved along with the hospital, that's a benefit that the specialty providers are able to get. And not only that, they are then able to learn what are those cost drivers behind variation so that they can improve. When potentially they are negotiating with payers, they are going to be able to have a lot more ammunition to recognize their superior performance compared to peers. And then finally, it strengthens the referral pattern between specialty providers and ACOs. It keeps churning and ensures everybody has a steady stream of patients coming in and revenue.
Okay, so thanks, Dave. And now we're going to talk a little bit about the hospital collaboration in team and go into the collaboration agreements, which this little bird signifies the specialist riding on the elephant here is going going to see what they can negotiate that is going to be really good for both the hospital and the specialists. So under team rules, hospitals bear the risk. That means that all of the risk, including the physician cost, anesthesia cost, sniff cost, in that episode that is above the target price, is borne by the hospital unless there are some other mechanism in play. And those play is initiated by the use of collaboration agreements. So here's what that really means, a breakdown of what the hospital really is responsible for in reality, and then those external factors which will also weigh in to the hospital under the team algorithm for risk. The episode costs are inclusive, but they're driven by factors governed by individual organizations. So on the hospital side, that means the surgical systems that they set up, their scheduling process, the staffing and who's involved in what procedures, their infection control processes, their blood management systems, et cetera, are all done by the hospital, and that affects the outcome or complications in these surgeries. On the external factor side, there are what the patient comes in with, like on the episode timeline. There are decisions of anesthesia agents or time of anesthesia or length that impact complications. There are surgical decisions as well, the approach to the incision, kinds of clinical decisions that are made throughout the process and before the process. And then, of course, there's the post-discharge environment in its entirety, whether the patient goes home or goes to a SNF or a rehab facility. All of these weigh into the total costs, and they all have risk components in them. So let's identify 4 of these key risk facts. The biggest team episode driver, as we see in the data, are complications. Team hospitals can develop collaborative agreements with dollar distribution, meaning benefits, to surgeons, to anesthesiologists, to other organizations that are part of it, to incentivize those organizations to work on the same kind of alignment. Requirement for the hospital to share downside risk, but team creates the possibility of alignment payments, or otherwise known as downside risk, to specialists and other participants as well. So it's somewhat open in its overall ability for the hospital to maneuver that. Doesn't mean that everybody will play, but it does mean that there's the capacity in the rules for these collaborations to occur. So let's go into the actual collaboration agreements and see what they must contain and what they are a little squishy on. So first of all, who are the collaborators? Well, that's a question for the agreements itself. It requires the participant must have written policies on the selection of collaborants. ACOs can be collaborators. As Dave mentioned, they're kind of a neutral territory. They can be collaborators as an organization that can facilitate team, for example, by providing data, by being a neutral territory for data, and so on. There have to be selection criteria for collaborators, quality and anticipated contribution, for example, to the team effort, but they cannot be linked to volume or value of referrals because that's a stark issue. They must have post-discharge referral to PCP services. So in that respect, ACOs and PCP organizations can be collaborators as well. On the financial terms for collaborators, the agreements have to define the terms for gain sharing or alignment payments, or both, and the timing and distribution of those payments. The gain sharing cannot be linked to volume or value of referrals. So this really is a departure from the days when the number of beds that get filled by particular surgeons is rewarded. It's not rewarded and can't be rewarded under team, specifically anti-reward here. Agreements have to be based on the enterprise level, so you can't punish a particular surgical team because of one bad episode. And beneficiaries can also receive incentives if they're connected to treatment adherence as part of the episode. Then there's some squishy areas that are not defined and need to be defined in the episode agreements. What defines quality, for example? How will physician versus hospital liability for quality or complications be assessed? How will it be determined? Choosing and limiting collaborators safely. If you know that you've got some quality issues in the shop, participating in surgeries in a hospital, can you safely eliminate that group? That will be an issue. Protection of peer review processes and reviewing episodes. Whole lot of data, a whole lot of decisions exposed that were never really exposed before in a process of looking at costs and what in hindsight could happen better next time. And that needs to be surrounded by a peer review process so that it is protected. And then, of course, data sharing across organizational boundaries. On the physician side, there will be private practices as well as salary practices of the hospital organization itself. And there are lots of sensitivities around the data, especially financial data or volume data. So that needs to be protected in some way, which is where the neutrality issue can come in.
Terry, sorry to cut you off, but I think we lost your camera.
Lost my camera?
Yes.
You're not seeing the slides, Dave?
No, I'm seeing the slides. I'm not seeing you.
I can't do anything about it until I get out of the slides.
Ah, well, never mind then.
Okay. I'm showing my camera being on, but I don't know what it is. I can't, I don't want to interrupt the presentation.
Nope.
Let me do that during yours and see
Sounds
if I
good.
can. Okay.
Sounds good.
Okay. Squishy areas of importance. We just discussed this, so I'm not going to go into any more. Now, what is a high-performing network of specialists? Well, as I mentioned, it's not about the reputation, it's about data. So we can make cactus bloom here, but it has to be backed by the data itself. Consensus-based measurement of quality. What does that mean? That means that in the collaboration agreement, there has to be an agreement about how quality will be measured, what complications will be measured, and who bears responsibility for specific kinds of issues in complications or in any part of the stay. This will require data sharing from and to all the parties while protecting the sensitive data. And as I mentioned, very necessary to have a peer review and feedback, especially the feedback. So when an episode comes in, it looks like high cost, the surgeon or the anesthesiologist or any person on the team needs to be able to respond on a platform as to what happened here and why that's occurred. So key agreements for a successful collaboration: use of the same analytics to define quality and cost across the entire team. You can't have different systems for different practices, different platforms competing against each other. There needs to be one team platform. Distinct accountabilities of the clinical team in the hospital worked out in advance. And data aggregation costs, it's a serious issue. As Dave mentioned, specialists by custom have not generally aggregated EHR data and have not had claims data in the past. Now it's the first time we'll be seeing claims data in addition to the possibility of EHR data on the specialty side. And so it will be very sensitive and it's costly to get that data. Okay, Dave,
All right.
what
So
will you need to do all this?
yes, indeed. And the first thing, I'm just going to keep hard charging right towards data aggregation. Hospitals, practices are all going to have disparate data sources. Can you advance the slide, please?
Yes.
Are going to have disparate data sources, and not only that, but for the first time for many specialists, there is going to be the opportunity to include those CMS claims. Word of warning here is that when we say data aggregation, we are not talking about matching up QRDA files from different sources, because that is not really a full data aggregation. Sure, that is something that may work for quality reporting, but QRDA stands for Quality Reporting Document Architecture, meaning that the file is strictly for quality reporting measures. And so it is not going to include things that these specialty groups are going to need in advance of or during a procedure. For example, it can be something basic like a previous diagnosis that the patient has, but since the provider is not getting claims, they may not know about that diagnosis. And it could be something more specific, something like patient risk factors for post-acute nausea and vomiting. So those are things that that we are going to need to know beyond QRDAs. Background work is critical in this data aggregation adventure. You need to know ONC status, who to contact, etc. So make sure that you do that in advance. We have actually built team episode analytics, and because we understand that participants are going to need their own set of analytics and episodes to look at cost variation and differentiate and identify the main causes for why one procedure or one type of procedure is coming out differently than others. We are the engine that aggregates all of this data so that you can see 360-degree patient view and understand exactly what is putting that patient at risk and where some of these downstream high costs have the potential to occur. It includes EHR data, so the non-billed clinical data, things like lab values, BMI, vitals, all things that can play a role in a surgical outcome that may not be known to a surgical care team in advance. And these do not start from scratch. We can tell you who are the what are the top 5 drivers of cost over the last 2 years, site provider comparisons right from the get-go, so that you are not trying to play catch up. You can start, there is no warm-up period in team. It starts on January 1st. Can you advance the slide, please?
It is.
There we go. All right. It just came through.
I said there's a delay.
Yes, indeed. All right.
Working live here, folks.
Working live. All right. The next thing that you're going to need is a communications platform. And I'm not talking about something where you can send messages, although that is something that is useful and something that we provide. But the data aggregation is necessary but not sufficient. Everybody needs to be able to see who these patients are and have that comprehensive view of that patient's medical history and their process from one end of the care continuum to the other. We're talking pre-procedure, procedure, and post-procedure beyond that CMS episode window. It should, for reasons I've described, include all episode events plus that clinical data in the EHR that is non-billed, but definitely valuable for you. And this is where hospital-based ACOs and clinical data registries can facilitate this view. What else is important is advanced notice. If informed about the surgical risks, the primary care provider or ACO, if applicable, can advise the surgical team in advance of some of these things. The surgical team, as we've said, may not know. They can ensure that the patient is an appropriate candidate for the procedure, which is surprisingly useful. We have seen in past analyzing some of these claims that some patients are not appropriate for surgical procedures based on recent medical history. Patient may be of an age range that is not really appropriate for it. And so when we look to see why some of these costs are so wildly variant from what we typically see, these are some of the things that we can get into, and that pre-procedure planning may play a huge role there. And again, that pre-procedure planning may include an anesthesiology visit and a post-procedural recovery plan, because that patient may not know how to necessarily advocate where to go next and what is expected post-procedure and what isn't. It's going to prevent things like unnecessary emergency department visits if the patient knows in advance who they can call to ask about whether or not something is required or is not. And then finally, the post-episode review. And this one is a little bit tricky because, yes, there are going to be variations in procedures. And so the goal, remember, their objective is to measure and improve outcomes over time. But to be able to do that, there are going to be episodes that are higher cost than others. So the best way to maintain this is through an approach of sort of a collegial learning environment. This is not meant to be a time to point fingers. This is meant to be a time to determine the root cause for unexpected costs. It's not something where you should necessarily say that everyone who had a high cost episode is bad and everyone else is good. It's important to recognize the reasons. So some of those may be higher drug costs. And if there was a medically determined reason that a provider may use a higher cost drug in another, that's something that needs to be taken into account. However, if there isn't, that is the opportunity to say, okay, well, maybe next time we use something else that isn't such a high cost if it is medically appropriate for the patient. There are going to be some uncomfortable conversations that come with this. We understand that, and that is part of what we mean when we say a high value network. We need to ensure that the patients are getting the best quality care that is possible. And so following these sessions, it's important to document findings and establish protocols going forward. So things like using different medications, using a different approach for a certain type of procedure if it is clinically warranted, etc. And then every month, these should be things that are followed up on to identify progress. And then also using your data analytics to track what has been the efficacy of these changes. Are we seeing improvement?
All right. Am I on camera again, Dave?
You are not, but that's okay. We still have the slides.
I can hear you.
Okay. I still have a camera. I found a little thing that I toggled, turned it off and turned it back on, but oh well.
They're stuck with me, unfortunately.
Okay, so before we wrap up, we want to hear a little bit more about your development in team. So we see this carrying the canoe over there to the water. So if you're starting out, would you like to hear more? Because we'd like to know, for example, this is really for our feedback. Are there areas that we're not covering? We would love to know that in the chat, or a question. You're definitely interested in these kinds of webinars, or this whole approach isn't for me, too hard, too complicated, and not worth it. That's the dead bird.
Dead bird. All right, so you will see this up on your screen here. And again, this is the polling question. Where are you in the development of team? Are you starting out? Would love to hear more. Are you definitely interested? Or just this really isn't for me? Maybe just here to learn. Okay, and by the way, if you're joining us late, this is anonymous, and so we're going to share the results here, but this is just kind of more for fun for you to be able to see where again you stack among your colleagues, and it also help us to know what we can do for future webinars and what if this is a topic of interest that you'd like to hear more about. So,
and we want to be the pretty bird.
That's right. We want to be the pretty birds, not the dead birds. So I think most people have voted at this point, and we'll show the results here in a second, but I wanted to give it about 5 more seconds for folks to weigh in. 4, 3, and 2, and 1. Okay, looks like about 38% of you are starting out and would love to hear more. So, which is great, pretty bird. 50% of you are definitely interested, which is great. It's an interesting topic. And then 13% of you, this isn't for me, which is totally fine. So it's a good spread.
Okay, thank you very much for that, for responding on that. Okay, I wanted to talk a little bit about what our platform has so that you can anticipate what you might be looking for in, similar or our platform for that matter. So we have team technology, and what you're looking at on the graphic on the right is a cost variation slide with a few things that we've put in that explain a particular procedures that we see at the top of the scale, meaning that they're higher cost, and a cluster of procedures that fall around the middle, which is typical of what we see. We see low cost, medium cost, and high cost. And then they're attributed to various trigger procedure clinical teams. What gets you here? What gets you to be able to look at procedures in any kind of context is secure data aggregation of both EHR and claims data, meaning that you can capture the patient ID, you can associate that patient ID across all of the different venues of care, and you can construct a start to finish episode of where that patient was, what happened during the procedure, and what happened after. Now, we have a platform that shows all episodes here, a variety of type. Some of them are payment models, some of them are conditions and procedures that we do for our groups so that they can see what their costs are and their quality issues. And so part of what we provide is a CMS team episode platform, if you will, that is specific to team. We create, as I mentioned, the ROGI value-based care episodes, which give you the longer view, because when you get the market basket from CMS that says, what is your aggregate cost over this time period, there will be some people who are starting out with a trigger procedure in Q1, and by Q4, you might have the tail end of some procedures, and so it gets truncated. A lot of what happens in the CMS episodes for EOM, for example, and other different payment models is that you're getting fluctuations that are not based on complete procedures or complete episodes. They're based on whatever entered and exited during this particular time frame. So we think it's important to distinguish that and see what really happened in an episode, no matter when it started. There are views by practice provider organization that you would want to be able to have, because obviously you need to know who's involved and identify teams, especially. Are there magic teams that are really high performers from a particular surgeon, an anesthesiologist and cardiologist, for example, working together? Customizable for clients, so every client has a unique configuration that they want to see, and we create special analytics for clients who are working on those kinds of things. And then our expertise is in working with complex clients. Most of our clients have Epic, and so we're really familiar with the data aggregation functionalities of a variety of skills in our our provider clients. So I want to give you 3 themes to wrap up what we're talking about today, and they depends on who you are. If you're a potential collaborator, meaning you are a specialist or you are an anesthesiologist or you are a SNF, what do you need to do now? Well, 1, you need to get expertise to build your history of surgical episodes and analytics so that you know what your history is. So that going into it, you can create a collaboration agreement that is based on that experience so you don't fall off a cliff. You want to evaluate your cost variation and your complications from the specialist perspective. That's different than evaluating it from the hospital perspective or someone else. So you need to be able to look at that. Know what you will need to take from the participant hospital to take on risk. For example, if you're in a specialty organization and you don't aggregate your EHR data by episodes, you will need that. And do you trust somebody else to do that on your data? So you will have to figure out the answer to that question and vet various organizations that are going to be doing data aggregation for yourself. And then who pays for that will be a big issue. And then what are your stop losses that you will need to have in your agreements? How much risk can you bear? So what if you're a participant hospital and everything's on your shoulders? Well, you'll need to evaluate your historical CMS team-related cost measure results because you have those. Especially if you have a surgical group or anesthesiology group, you will have cost measures that are relating to them under the MIPS program as well. So those are important to review before you construct your network and your applications to be able to look at team procedures. You'll need to develop your communication platform for clinical team members. It's so time sensitive what's happening that you will need to understand, or you will have to look at the programs that you're responsible for as a hospital. Let's say infection control, that when an infection is actually triggered, that's not the time when you want to be pulling out what your hospital infection plan is. You need to be able to have that in advance and figure out the variations in that depending on the type of episode and what's happening. If you have blood management responsibility, do you have a store of the patient's own blood to prevent any kind of problems with other blood? Those are issues that you'll need to consider. Consider using an ACO for data aggregation and episode analysis. If you have an ACO or you're participating in an ACO, I think it's important that you recognize that an ACO has had a history of value-based care where you've been a participant, but not necessarily responsible for the management of risk and management of patient risks. If you're an ACO, you have a distinct flight path here. Team can be your first foray into optimizing specialty care, and your second will be ASM. It's an enormous opportunity for ACOs to actually start developing a high-performing network and reaching out to specialists and closing the fractures in the healthcare system that patients are experiencing. Improve your actionable data through specialty episodes for team and ASM. You'll be able to see what that data looks like for your patients and then what kind of services those patients are going to need across the spectrum. Your information and your alliances with SNF will be even more important as a result of these payment models. And then, of course, you can enhance your value-based care role within your health system by playing a more important part and not sitting on the sidelines in such an important payment model. And that's it. Garrett, we're open for questions. We've got quite a few minutes left.
All right, great. Yeah, we do have some questions here. And Terry, if you wanted to just like unshare and then come back on and see if you could turn your camera on if you want to, or either
Yeah.
way for the questions. There you go. Let's try it. Um, give that just a second to see. Yeah, we're still not getting your camera. That is odd.
That is really.
Oh,
Here
there
I
you
am.
are.
Okay, so the camera that operates on the slide thing panel is not the same camera that I can access here.
I
That's
guess not. All right. Well, hey, we're learning something every day. Okay. Well, we do have a few questions here, and if, by the way, if you do have a question for either of our speakers, for Dave or to Terry, just use your control module as the attendee, and there is a space specifically for questions. We're going to get to as many as we can. If we don't get to yours, don't worry though. Someone will reach out via email to make sure we get that answered. Okay. Let's dive right in. First question is this. We are a low volume ACO, no surgeons or hospitals, but is team still relevant for us?
Ooh, I like this one. Yes, it is. I just jumped right in, Terry. If you've got more to add when I'm
Go for it,
done.
Dave.
All
Go
right.
for it.
Cheers,
Yes, it
Dave.
is,
Claim
because
it.
the patients are going to be getting these procedures no matter what. You are responsible for the total cost of care. And so whether or not you are necessarily aligned with a particular hospital or aligned with a group of surgical providers, the patients are going to be. They are going to have these procedures, and they are going to come back to your total cost of care for your patients. And so, yes, it is important for you to understand team and how it will impact your ACO. It's not something that is a specialty thing that you don't need to worry about. It actually is something that will play a role in your potential shared savings.
And let me add on to that, because of the PCP referral requirement in team, that for those patients who are coming in, let's talk about the orthopedic serialists, of which I'm a proud orthopedic serialist.
You and me
Don't
both.
visit my primary very often, but I love the
We'll all
orthopedic
get there. We'll all get there eventually.
specialty. And so you may not even have a primary on record. So it's important to be able to trigger that provision to refer through the ACO so that that patient is in a value-based care program.
Great. Okay. Next question here is also, we are a private group, and our affiliated hospital is consistently in 1-star territory. Are we at risk because of them?
That is, it will depend. You are not, as far as team in general goes. The hospital is the one who is selected as the participant in team. But that is something that if you are in a collaboration agreement with that hospital, that is something that you will need to address in terms of gain sharing and quote unquote alignment payments. That's something that's very critical to know and very critical to understand, and why some of the analytics that we've been discussing are so helpful, because you will be able to see which of these costs are associated with things like hospital acquired conditions or issues that are complications from the procedure itself.
Right.
Terry, did you have anything to add?
No, I think that's a good answer.
Oh, okay.
Yay.
Very good. All right. Next question here is, how do we find out what our primary cost drivers were?
That's a good question, because you don't necessarily, if you are coming into this, particularly as a specialty provider, you don't have a history of claims data to look at. And so, right, how would you know what your primary drivers of cost were? Because you can see, you don't have all of the information about the dollars. You can see what you billed, but that's all you can see. But in there is actually how you can do it, because what we have developed is, we developed this actually before people were getting claims data, and we were able to look at the professional billing charges. So even though it wasn't through the hospital, you can still see what was professionally billed, so that you can see where some of the, what we refer to as notable observations occurred. So things like DVT, coding for complications, sepsis, post-op nausea and vomiting, things that are all coded that you can start to look at as potential drivers for high cost. So even before you understand the dollars and cents of it, you can still see what those notable observations are that give you some idea of where your pain points may be.
Yeah, because a lot of the things happen after that operating room, and the surgeon may not even know. So if when the episode gets created, that information, which happens later in a stay or even outside the stay, the DVT happens after the patient often leaves the hospital. And, it gets revealed by the episode, and then where's the issue lie? What happened during the hospital stay? Was the patient, did the patient have any prophylactic DVT prevention, for example? What was the surgery schedule looking like? Did the patient have to rest in a bed because the surgical schedule was kind of a mess? And so there was a delay in surgery and the patient developed a DVT. So there's a lot of things that will be uncovered once the data comes together from all of the different sources.
Awesome. Well, that actually concludes our audience questions, but I actually have a question for our audience. And that is, if there is anything, I know we've covered so much stuff today, and in all of this, and there's a lot of details, and we're almost so close to it that sometimes we don't know what either doesn't make sense or doesn't resonate or could use a little bit more clarity. So if there's anything that you would want to have Terry or Dave expand on in a future webinar, please drop that into the question. There's going to be a little survey that launches after, and it'll give you a spot to answer that as well. But if there's just something on your mind, even from today's presentation or part one, that you just didn't understand, and you would like us to expand on, please let us know. There is, by the way, a part one to this. And if you would like to watch part one, I'm going to actually drop the link here in real time into the chat for everyone so that you can see that. And I'll also have that in the thank you note that we're going to send out to everyone. And that way you'll be able to see part one and catch up a little bit if you are feeling behind. But that's actually going to wrap up our presentation for today. And my internet is very slow, so I'm not able to access the link in real time, but that is okay. I will include it on our thank you email. So thank you all so much. Thank you, Terry, Dave. As we wrap up here, Terry, I wonder if you could pull back up your slides, and wanted to encourage you all to head over to.
I need to be able to share it, I think.
Am I not? Let's see. Should be able to do that, but let me.
Let's see.
Here, I'll make you the presenter again.
It probably will go back into a.
Thanks for bearing with us, folks. We are, as we said earlier, are working live. And by the way, while she's doing that, I did find the link here, and this is for part one. I put this in the chat, and so you should be able to access that, and that'll take you there. And there's the slides as well, so you can get caught up. Yeah, so what you're seeing on your screen now is the virtual exhibit booth by Roji Health, and this is available at vbcexhibithall.com, where you can check out not only a lot of resources about them and read up more on what they're doing in space, and of course contact them through there, but also all the webinars that we've done. And we've done, I think, more, I can safely say, with Roji than any of our other clients. So, in fact, I think our very first webinar was with you guys. And so we've been together for many years. Yeah, over hundreds of webinars later, and we're still doing them together. So there's a robust archive of of reference material that Terry and Dave have put together through the years that you may be of interest to. So if you're looking for just a great solid education on all these different items, or again, if you want to know any more, go to check out VBC Exhibit Hall. And then finally, if you'd like to reach out to Terry or Dave directly, feel free to do so. Their information is on this final slide here, or I'm happy to facilitate an introduction directly if that's easier. So feel free to reach out to me as well. But thank you all again so much for spending your afternoon with us, and we hope that you join us on the next one. Thank you very much.
Thanks, everybody.
Thanks, everyone.